it probably would have been a good thing to have a vote to ask if people think that the answer to the question, should hypofractionated radiation treatment be the standard non-surgical treatment of prostate cancer, yes or no, and then we could do that again at the end. But I guess we can figure that out in the question and answer session that will follow. So we'll have a panel discussion, which will also include John Kalapurikal at that time. So to start off, as Ashley said, we are radiation oncologists who are at the Proton Center at Delnor and at CDH. And the four of us, plus Mike Stutz, see most of the prostate cancer in those sites. And then Amit Bhate also sees prostate cancer patients out at Kishwaukee. Let's start off with Stephen explaining what hypofractionation is and the background and rationale for this treatment.
Well, hello, everyone. This is Stephen Mihalsik. I know I've met many of you, as Dr. Hartzell just mentioned. I'm one of the radiation oncologists out here in the West region. I practice at the Proton Center and at the Delnor Cancer Center in Geneva. I'm going to tell you a little bit about the background and the rationale that forms the basis for this talk and this question about whether we should be using hypofractionation in prostate cancer. I feel like I would be remiss if I didn't give you some of these historical pictures here now in the public domain of some of the founders of our field of radiology and radiation oncology. On the left, you see Wilhelm Röntgen, a German physicist in the 1900s. He actually discovered and named X-rays in 1895, which were emitted from a light enclosed tube, then exposed to photographic plates. That picture in the middle was one of the very first ones that was ever created, a picture of the bones in his wife's hand wearing her wedding ring, that very year that he first identified these things called X-rays, frequently referred to as Röntgen rays when they were first identified, even though he called them X-rays. On the right, you see Irene and Marie Curie, who would come along only a couple of years later with the identification of radium and polonium with her husband Pierre, Becquerel in there 2 years prior with uranium, all these radiation emitting substances, which would go on to form the foundation of so much that we do in radiology and radiation oncology. They were used medically soon thereafter, even in that first year in 1896, with publications using diagnostic radiology, identifying metal in patients who were injured almost immediately in many papers that would follow in 1896. And soon thereafter began use in therapeutic purposes, not just diagnostic, but therapeutic purposes, when it was appreciated that the radiation could have some impact on superficial tumor growths or superficial lesions like moles. So it was only years later that would take place. And in the early 1900s, there was really a vast advances in the use of therapeutic radiation with the use of radium superficially. Of course, we've come a long way since then. 100 years later, we're using modern radiation for prostate cancer now, often with a linear accelerator, which is the robotic type of device that you see illustrated on the right, that machine that's mounted and rotates around the gentleman on the couch there in the middle of the room in that photograph, and delivers X-ray or electron radiation, although we use X-rays to penetrate deeply into patients like for prostate cancer, here aimed at his chest. When we do radiation like that, we give little bits of radiation daily, Monday through Friday for many weeks, and that way of delivering radiation with small bits over many days is called fractionation. We have the prescribed dose, the total dose that we intend to deliver to, say, the prostate gland, broken up into fractions delivered over many days and, in fact, many weeks. When we do it that way and we give a small amount per day, often 1.8 to 2 gray per fraction, the dose, those are the units that we use to describe the prescribed dose, it's called conventional fractionation. And we often do it with this device illustrated here, a linear accelerator. It can also be done with a cobalt type device that would look very similar. It can be done with proton radiation, like the tools that we have at the Proton Center in Warrenville, also an external beam of radiation that can be given in a fractionated fashion. It can be given with SBRT. I'm sure many of you have discussed SBRT type treatments. And it can be given with brachytherapy, with radiation seeds that are actually placed in or on the body to deliver radiation directly with a radioactive substance like palladium or iridium or iodine. In this case, we're talking about the prostate, of course. This CT scan image gives you some sense of the challenge that a radiation oncologist is up against when they're trying to deliver a full effective dose of radiation to the prostate in anyone who is diagnosed with prostate cancer. In this image, you can see the prostate outlined in the magenta and the center. You can see the bladder outlined in yellow and the rectum in brown, the sigmoid in blue. When we deliver the radiation, we intend to give the entirety of the prostate the whole prescribed dose, 100% of the prescribed dose of radiation, but somehow we also want to give very little radiation to all of the organs at risk that are nearby, meaning the bladder, the rectum, the sigmoid, the femoral heads. It isn't possible to give no radiation to those nearby things, because if we're going to give all of the radiation to the full edge of the prostate, we have to necessarily give all of the radiation to the things that are actually physically touching the prostate. And there's a fall off area where the radiation diminishes as we get farther from the target with all these different approaches to radiation treatment. What's illustrated here in this particular diagram are the isodose lines, the amounts of radiation depicted with a colorful topographical type map type description, showing you the effective prescribed dose in a ring around the prostate gland, and the fall off of the radiation beyond that is illustrated by the 50% isodose line in orange. But it does illustrate that the rectum is going to be exposed to some radiation, as is the bladder and other nearby structures. And that's our fundamental challenge, is how to deliver that high amount of radiation safely to the prostate, but still not harm all of these nearby tissues. In the past, what we thought when we were first discovering radiation in the early 1900s, we found that the use of high doses of radiation with an X-ray tube type delivery would cause significant reactions, toxicities, especially to the skin, and wasn't that good at getting tumors to shrink. On the other hand, where they were using radium, like in France, there was some better tolerance of the treatment, meaning that the toxicities weren't as severe, and there was some more efficacy. The tumors were more likely to shrink when we were giving the radiation slowly over a more prolonged period of time. They elaborated this effect with experiments in testes, which showed that the spermatogonia, these rapidly dividing cells in the testicles, could be eliminated with a fractionated delivery of radiation given over several fractions, while the testicles themselves could remain intact with stromal survival in those testicles. And we interpret that now that those rapidly dividing tissues are more sensitive to the radiation treatment, whereas the mature tissues, which are not dividing or dividing slowly, are less sensitive to the radiation treatment. And that the fractionation allows us to see that difference. On the right in this kind of complex diagram, you're seeing things called iso effect curves, which demonstrate the relationship between the total dose of the radiation on the y-axis and the fractionation, how much the radiation is split up into small fractions on the x-axis, so that you can achieve higher doses as you go to the right on the x-axis, more fractionation to smaller bits of daily radiation. But one of the things that we want to take away from this iso effect graph is that there are some tissues with steep curves where you can give, if by using fractionation with smaller and smaller fractions, you can get to higher doses. And there are some tissues with very flat curves where fractionation does not allow you to get to a higher dose of radiation. This differential effect of fractionating the radiation is the fundamental reason that we do it, because there are late responding tissues that will be spared by breaking the radiation up into small bits, and early responding tissues, like most tumors, that are not so much spared by breaking the radiation up into small bits. So we can then break it up into small bits, achieve a very high dose safely, and be more likely to eliminate the tumor. We understand this now is more related to the biology underlying it, related to the function of the radiation in the cells. When we use an ionizing radiation treatment, it oxidizes molecules within the nuclei of the target tissues, and that harms the DNA, causing DNA double-strand breaks, single-strand breaks, and other types of damage, which allow those tissues to express injury. tumor cells are uniquely susceptible to this type of damage because of problems in their DNA fundamentally that allowed them to become tumorous in the first place. But there is a variety of responses to radiation treatment as illustrated in those ISO effect curves from the previous page. And we often summarize that with a parameter that is called the alpha-beta ratio. That alpha-beta ratio comes from a linear quadratic model, a description of the way that different tissues respond to the radiation treatment. But it gives us this single parameter, alpha-beta, that then describes how responsive these tissues are with respect to fractionation. A low alpha-beta, something in the range of 3, is a descriptor of a late responding tissue, which will express its injury as a late toxicity years later and is more tolerant to the tissue, to the radiation, and more spared by the fractionation. Whereas a higher alpha beta, something in the 10 range, is going to be something that is an early responding tissue and expresses the damage of the radiation early, like the skin with dermatitis during radiation treatments, or like tumors when they're rapidly dividing. So broadly speaking, we often use the alpha beta of 10 as a surrogate for most tumor alpha beta ratios, but that may not be the case when we come to the specifics of various cancers. And it's been the subject of a lot of debate and research, exactly what those alpha beta numbers might be, both for normal tissues and for particular cancers. So I spent all this time up till now telling you that fractionation is a concept in radiation that has allowed us to deliver effective amounts of radiation safely. So why would we want to do something like hypofractionation, like use fewer fractions, when using many fractions has worked so well for us to deliver the radiation safely in the past? Well, the first reason is obvious: resource utilization. If we could get the same effective treatment done safely without increasing side effects in fewer treatments, then we would love to do it. Furthermore, there's some evidence that there might even be increased efficacy in treating tumors when we use hypofractionated approaches. In particular, again, referring to those SBRT type approaches where we use a stereotactic approach with very high doses, say to the brain, where we call it SRS, or to other places in the body. There are unique responses. We can effectively ablate the tissue in that target area and really expect that we've totally destroyed something in the target. So hypofractionation can offer us that kind of approach and benefit. And for that matter, technological advances in the many years that we've had radiation have allowed us to safely deliver the radiation in more conformal, precise, and accurate ways, more narrowly to our targets. And if that means that we're exposing less nearby organs to danger, we might be able to deliver these effective amounts of radiation in shorter periods of time more safely. And Dr. Akhtar is going to go into more detail about what those advances have been that allow us to do that. And lastly, really about the alpha beta, we're really relying on the idea that there is selective tumor killing when we use more fractionation. But that may not be the case. As I mentioned, alpha betas have been a subject of a lot of debate and research, and it could be the case, in particular with prostate cancer, that by increasing the fractionation, we might be sparing the prostate cancer more than we're sparing some of the neighboring organs at risk. In this final slide there, at the bottom of this final bullet, you see some estimates for what the alpha beta ratio might be for the prostate cancer. It could be even lower. Rather than that 10 that we often use as a surrogate for tumors, it may be more like a late responding tissue with an alpha beta more in the 1 to 2 range, where the rectum might even have a higher alpha beta ratio than that. So in fractionating the radiation, we might be selectively sparing the cancer rather than the organs at risk, really achieving the opposite of what we want to achieve when we're using conventional fractionation. And so in prostate cancer, it would be lovely if we could deliver the effective amount of radiation without increasing patients' side effects substantially in a shorter period of time to both reduce the cost and the logistical burdens of treatment. And we might have some side benefits too in efficacy. The prostate cancer fractionation schedules that we use today, we group in 3 main groups. We call them conventional fractionation, moderate hypofractionation, and ultra hypofractionation, When we deliver it in the more traditional fashion of using 1.8 to 2 gray per day, we call that conventional. And then it takes us somewhere between 7 to 9 weeks to deliver the radiation in that fashion. Still a fully appropriate standard of care approach to delivery of the radiation. But if we could do it faster, as with moderate hypofractionation, it means delivering between 2 and 3.5 gray per day. And that means completing radiation for prostate cancer in 20 to 28 treatments or 4 to 6 weeks. If we deliver it with even more radiation per day, upwards of 5 gray per day, we do it in 1 to 2 weeks. And that's called ultra hypofractionation. These are described in the current versions of the NCCN prostate cancer guidelines, which are excerpted there in the table on the right-hand side. And again, we'll go into more details about these specific regimens in the remainder of the talk. With that, I do want to hand it off to Dr. Akhtar, who's going to elaborate a little bit on the advances that have allowed us to use hypofractionation to increase the dose per day.
Thanks, Stephen. Adil Akhtar here. Can you all hear me okay and see my screen?
We're hearing you and seeing it, Adil.
Okay, wonderful. I'm one of the radiation oncologists who works at the Warrenville Cancer Center and also next door at the Proton Center. Just wanted to thank everybody on the call today in advance as well for allowing me to be a part of this talk. The title of my section is called Optimizing Therapeutic Ratio Through Advanced Techniques During Hypofractionated Radiotherapy. And really, this section is meant to give a sense of the techniques we use to ensure that we are maximizing the radiation dose being delivered to the prostate and minimizing the dose being delivered to nearby organs at risk. While this is a basic principle in all of radiation oncology, it becomes increasingly important with hypofractionation, where Stephen described large doses are being given per treatment, and the potential for toxicity is higher if not given with precision. So just to outline for what we'll discuss here, there's a few methods I wanted to highlight, which include external immobilization, optimizing internal anatomy, image guidance during treatment, and a couple modalities in terms of radiation therapy delivery, including intensity modulated radiotherapy and proton therapy. The approach to hypofractionated radiation therapy planning starts where all radiation treatment planning starts, which is a CT simulation or radiation therapy planning scan. There are a number of components to this step, but the key aspects include positioning of the patient in an extremely reproducible way. And to aid in this goal, there's creation of an immobilization device as shown in the middle panel here. And that's designed to minimize motion of the pelvis during treatment to less than a few millimeters, what we term intrafraction motion, and also to minimize differences in position of the pelvis between each treatment as it's given across separate days, what we term interfraction motion. After creation of an immobilization device such as this, CT images are required, and then a behind-the-scenes process begins with our physicians, medical physicists, and dosimetrists. The details of that process are beyond the scope of this lecture, but in regards to hypofractionation, a few key considerations include using smaller margins we place around the prostate, in addition to a more stringent set of limits in terms of how much radiation normal organs can receive, such as bladder, rectum, and bowel. We term these limits dose constraints and must be cognizant of using a separate criteria of dose constraints for hypofractionation compared to conventional fractionation. Taking one step back, prior to undergoing a CT simulation, one technique to reduce radiation dose being delivered to the rectum is application of something that many of you are familiar with, SpaceOAR hydrogel, which is an absorbable injectable material that provides space between the rectum and prostate. This is done under transrectal ultrasound guidance, as shown on this bottom left picture here. And the actual hydrogel is injected transperineally. The axial image on the right is actually a fusion between a radiation planning CT and a diagnostic MRI, where you can see the prostate outlined in orange and a typical margin that is added to the prostate in red to account for variations in day-to-day setup. You can see that this margin falls into the space containing the hydrogel, as opposed to the anterior rectal wall, which it would otherwise lie in without this gel in place. In terms of data, a phase 3 clinical trial in 2014 showed a statistically significant reduction in acute rectal pain, late rectal toxicity, and bowel quality of life with the use of hydrogel compared to not. Some feel the magnitude of this benefit was modest, making its use variable across centers. However, of note, this trial was done with conventional fractionation, and in a setting of hypofractionation, where there's larger doses being used per fraction, it stands to reason that the benefits with use of a technique such as this may be even more pronounced. Other so-called techniques include bringing it back to the basics and trying to leverage normal anatomy to reduce the amount of normal tissue within the high dose per fraction treatment field. This includes instructing our patients to maximize bladder fill in a still comfortable and reproducible way. This allows for a smaller proportion of the bladder to be in the treatment field and usually elevates loops of bowel up and out of the treatment field. Reproducible bladder fill also allows for reproducible prostate positioning. And similarly, having the rectum be consistently empty through avoiding foods associated with gas or constipation will minimize the amount of rectum that's going anteriorly into our treatment field, but also minimize anterior to posterior displacement of the prostate in and out of the treatment field. Another strategy that can be used to reduce radiation dose to the rectum is an endorectal balloon. This can be utilized during treatment planning process and during each daily treatment. What it does is it displaces the posterior wall of the rectum out of the treatment field as shown here in this axial image, and it allows for positioning of the prostate to be more reproducible. With the advent of space-wear hydrogel at our center, in the intact setting, this really is now reserved for only a few patients in whom we cannot successfully inject hydrogel due to technical factors or various oncologic factors that preclude placement of hydrogel, such as posterior gross extracapsular extension. We've covered external and internal immobilization. Another key technical component is the ability to visualize the prostate position prior to turning the radiation beam on. What is used at the Proton Center and in many other centers is radiopaque fiducial markers. Each day during treatment, a pair of radiographs oriented 90 degrees to each other independently confirm the position of these markers, which serve as a surrogate to the position of the prostate. At our center, these are inserted during the time of hydrogel placement in a manner similar to the process I described previously with transrectal ultrasound guidance. Another powerful tool available on X-ray-based linear accelerators is something called a cone beam CT, which entails a KV source and an imaging panel directly opposed to it to rotate 360 degrees around the pelvis and allow for generation of a mini CT scan without having to move the patient. This mini CT acquired prior to treatment is overlaid on the treatment planning CT, which all our dose calculations and planning is based on. A perfect setup would include one cohesive image that matches line on line and looks like one image from one certain day, although in reality it's from 2 separate days and 2 separate images. This cone beam CT is particularly powerful when combined with the 6 degree of freedom treatment table, which can make millimeter adjustments in 3 translational and rotational axes. This degree of precision, again, is very important when giving high doses per treatment, such as what we do during hypofractionation. Just a couple more slides. In terms of actual radiation modalities to be used with hypofractionation, IMRT, as many of us know, is a sophisticated form of radiation planning whereby many radiation beams with varying angles, field shapes, and intensity across the field are used. This results in the high dose region being limited to a small volume around the prostate, or in other words, having a high degree of conformality. Due to the complexity of available combinations, this type of radiation planning usually requires a computerized algorithm to optimize the best beam and field fluence selection. Lastly, in regards to proton therapy, this is another safe and effective approach available here in Warrenville and overall across the country, currently 37 centers, I believe, at present time. The interest in use of proton therapy stems from the physical properties of protons, largely due to the fact that these are heavy charged particles their interactions with matter in the human body are such that they travel a certain distance before depositing the vast majority of their energy in a given location. In other words, they stop. Furthermore, through advanced technology, we can modulate the depth and position of these protons within the prostate such that spot by spot and layer by layer, the radiation dose being deposited can be carefully controlled. The end result is maximizing radiation dose to the prostate while minimizing radiation dose to the bladder and rectum, a goal which, again, is of increasing importance as high doses per treatment are used during hypofractionation. With that being said, I will hand things over to Nasser in terms of the actual clinical data to support the use of hypofractionation.
Hi guys, Nasser. Thanks for being here. You guys seeing my slides?
Yes.
Okay, so I'm presenting moderate hyperfractionation, the data. So fortunately, ASCO, Astro, and the AUA got together in 2018 and put together a consensus panel and published these guidelines for the use of hypofractionation in the setting of localized prostate cancer. We're going to go over the data for moderate hypofractionation within the context of these guidelines. So the definition of moderate hypofractionation, 2.4 to 3.4 gray per fraction. There's plenty of data, right? There's lots of data for the use of hypofractionation in the setting of localized prostate cancer. We're going to focus on 4 large prospective randomized controlled trials that total in more than 6,000 patients. We've got CHIP, PROPHET, RTOG 0415, and the HYPRO study. So there's really two types of trials, right? There's superiority studies and there's non-inferiority trials. And the purists will say that we should be focusing on the non-inferiority studies for this, and that's kind of what we've done. That's what the consensus panel looked at. So those are the CHIP, PROPHET, and RTOG 0415. I included HYPRO, which is a superiority study, just because it's a large trial. And the other thing to keep in mind, a housekeeping issue, is that the biologic equivalence, all the stuff that Stephen talked about in the beginning, you know, it all boils down to, is it an equivalent dose between the arms of the study, right? So the biologic dose can vary amongst the hypofractionated arm and the standard fractionated arms, and that can play into whether or not you can compare the outcomes of the trial as well as the toxicity. So here they are. These are the 4 large trials. We'll talk about CHIP and PROPHET together. The reason for that is that the hypofractionation arms in those trials were similar, right? They both use 60 gray in 3 units per fraction over the course of 4 weeks. All in the CHIP trial, you had low, intermediate, and high risk patients represented. In PROPHET, there were only intermediate risk prostate cancers included. Androgen deprivation therapy was used in the CHIP trial. The next study is RTOG 0415. The fractionation scheme in that trial was a little bit different. They used 2.5 units per treatment over the course of about 5.5 weeks. This trial only included low-risk prostate cancer patients, so no ADT was given. HYPRO was a little bit different. So this trial the hypofractionation arm was 3 treatments per week over 19 fractions total, 3.4 units per fraction. And actually, we'll get to this a little bit later, but the biologic dose in the hypofractionated arm of the HYPRO study was higher than all of the other hypofractionation arms that we're going to talk about. And that trial included both intermediate and high risk prostate cancer patients. So what can we say about the outcomes, right? So we can say that hypofractionation, based on these 4, or actually the first 3 large randomized trials, that hypofractionation was not inferior to standard fractionation. Again, the HYPRO trial was a superiority study, and it found that hypofractionation was not superior to standard fractionation. The other thing I want you to focus on this trial is that the median follow-up is typically on the order of about 5 to 6 years with these 4 trials, except CHIP last year published in abstract form and presented at ASCO GU their 9.2-year median follow-up update, and in fact, non-inferiority continues to be the case. This is just in here to show you that there's more than just those 4 trials. There's other single institution studies that looked at moderate hypofractionation versus standard fractionation, and we can confidently say that the evidence supports similar early cancer control with hypofractionation. Can we make any statements about outcome by risk classification? So if we look, certainly the most robust data comes from the low and intermediate risk categories. That's more than 5,000 patients amongst these 4 large trials. But high-risk prostate cancer patients were also included. You had about 1,200 patients if the superiority trials were included. Important to note that when they treated either with standard fractionation or hypofractionation, nodes were not included with patients treated for high-risk disease. The 2 studies that stratified data based on risk group, that's the CHIP trial and the HYPRO study, and in both trials, there's no significant interaction between treatment effect and risk group. So what does the consensus panel say? For low-risk prostate cancer patients who decline surveillance and receive EBRT to the prostate, moderate hypofractionation should be offered. This is a strong recommendation with high-quality evidence and uniform consensus. The same can be said for intermediate-risk prostate cancer patients. Again, moderate hypofractionation should be offered. In patients with high-risk prostate cancer, again, these trials did not include the pelvic lymph nodes. The consensus panel supports the use of hypofractionation. Strong recommendation, good quality evidence, consensus not uniform, but still very good. So this slide is just in here to show you that we can, in fact, treat the prostate and the pelvic lymph nodes using hypofractionation. I know that's not what was done in the studies, but what we're doing here is it's called a simultaneous integrated boost. So while the prostate, outlined in red, that's the dose cloud, is receiving 2.5 units per treatment, the pelvic lymph nodes are being treated with a standard dose at 1.8. And so you get elective nodal treatment to 50 units is typically what you do for something like this while the prostate is being treated definitively using hypofractionation. So this is often how we use our hypofractionation while treating high-risk patients. Other institutions do this as well, and it's a nice, convenient way to get it done while getting the patients through in 28 fractions. Now, the discussion of whether or not to treat pelvic lymph nodes, that's way beyond the scope of what we're talking about today, but it can certainly be done. So shifting gears a bit and talking about toxicity, what we can say based on these 4 large trials is that acute toxicity is similar for GU, but there does appear to be higher acute GI toxicity with moderate hypofractionation. This was shown in 3 of the 4 large trials. And going further, we can say that this is based on the data from the CHIP trial, is that bowel toxicity and bladder toxicity tend to occur earlier when you're using hypofractionation. So the purple and the red curves here represent hypofractionation. The blue is standard fractionation. You have bowel toxicity and bladder on the right. And what you're seeing is that, well, first off, there's higher toxicity with regard to bowel grade 1, grade 2 when you're using hypofractionation, and also those curves tend to peak earlier. And then with bladder, the peaks are the same, but again, compared to standard fractionation, you can tell your patients that they're likely to experience side effects a little earlier. Late toxicity. We're gonna go back to what we mentioned earlier, that similar biologic doses, it's important to know what the biologic equivalence is in the comparator arms when you're looking at these trials. And so again, we're going to group the CHIP trial and the PROPHET trial together. And the arms in the study had similar equivalent doses when you break it down to 2 gray equivalent per fraction. And what we're seeing is that between the comparison arms, hypofractionation and standard fractionation, late toxicity, GI and GU were pretty similar. So similar biologic doses result in similar late GU and GI toxicity. In the other two trials, RTOG-0415 and the Hypro trial, these biologic doses were not so similar. So RTOG-0415, the hypofractionated arm was an equivalent of about 80 gray, while the standard was about 70. Hypro, again, this is the study that went way beyond the other hypofractionated regimens in terms of the dose equivalence. And what you're seeing is that you tend to see a little bit more increase in the late toxicity, both GI and GU in RTOG-0415, and in the Hypro trial, higher grade 3 toxicity with the hypofractionated arm. Important to note here is that one comment that comes up is that this dose that was used in RTOG-0415 in the standard fractionation arm, 70 gray, we typically go beyond that now. So you could say that the standard fractionation arm in that trial was borderline inadequate, a little bit lower than what we would typically use at this point. So the consensus statement on toxicity. The panel says that there's an increased risk of acute GI toxicity with moderate hypofractionation. We saw that. And I'll add the point that certainly acute toxicity tends to occur earlier with hypofractionation. Late toxicity, if you're comparing equivalent arms with biologic equivalents between conventional and hypofractionation, those late toxicities should be equal. So what hypofractionation regimens does the panel prefer? Well, the most robust data is with 60 gray and 3 gray per fraction. That's the CHIP and PROFIT. That's over 4,000, or sorry, almost 4,000 patients. You had all risk classifications included, low, intermediate, and high, and you also had data on the use of concurrent ADT. For the other trial that the panel liked was RTOG-0415. That's the 70 gray over 5.5 weeks, and this is often what we use when we decide we want to treat the pelvic lymph nodes with that technique that we illustrated earlier. The panel did not like the Hypro regimen. That's 64.6 and 3.4 per fraction. Again, that's the superiority study that did not show an advantage to hypofractionation and in fact showed higher toxicity. So that one is not recommended. What about patient selection? Who should we offer this to and who's not a candidate? Really, the hypofractionation, it should be offered to everyone, regardless of age, comorbidity, anatomy, or urinary function, according to the consensus panel. And the reason behind that is, well, the studies didn't really break down outcomes by the metrics we just mentioned, right? So there's no data to suggest that there's excess toxicity by subgroup. There wasn't really a subgroup analysis in any of the 4 large randomized trials, but we can make some common sense statements and say that patients with higher baseline symptoms are more likely to have acute and late toxicity, regardless of whether you choose conventional or hypofractionation. And I'll leave you with this. This is the task force's conclusion with regard to moderate hypofractionation, and I'll read this verbatim. Moderate hypofractionation holds important advantages in terms of patient and resource utilization. On the basis of this high-quality evidence, a strong agreement has been reached within the task force that moderately hypofractionated EBRT should be offered to patients choosing EBRT for treatment of their prostate cancer. This recommendation holds across all risk groups. In patients who are deemed candidates for EBRT, the decision to offer moderate hypofractionation should not be affected by considerations of age, comorbidity, anatomy, or baseline urinary function. From the ASTRO, ASCO, and AUA, That's my last slide before I turn it over to Bill for a discussion on ultra hypofractionation.
I had trouble getting my mute off there. Thanks, Nasser. So in the interest of time, I'll use these short schedules of treatment to give a short presentation on ultrafractionation. This is one of those things where what's new is actually old. On the left side, you'll see the recommendations or the divisions of moderate, conventional, ultra hypofractionation. And as Stephen said, I've blown it up a little bit at the bottom left. The ultra hypofractionation is either in 5 treatments. That's more common in the US, 7 fractions more common in Europe, especially because of the Scandinavian trial. But 6 gray times 6 was used many years ago at St. Thomas in London over a 20 plus year period. Patients with apparently localized prostate cancer were treated, realizing that this is a different era of diagnosis, grading, no PSA, and different way of diagnosing these patients. But they treated 232 patients with excellent results in terms of survival. Compared to the patients they were treating with conventional treatment, there was no major early or late morbidity. And one of the famous patients who received this treatment was the actor Laurence Olivier, who was treated in 1967. He lived until 1989 into his 80s without any significant complications from that treatment. So this is not a new treatment. However, the techniques have improved. As Adil said, we're much better at treating smaller areas. So one way of doing this is to do something called stereotactic body radiation therapy. SBRT is defined in this country as 5 treatments or fewer, and that in part is based on it doesn't get paid for if it's more than 5 treatments, or it doesn't get paid for SBRT if it's more than 5 treatments. So that's unfortunately forced us to use this regimen as the primary treatment of 5 treatments. There was a compilation in 2019 of 12 different studies, 2 of them multi-institution and 10 of them were single institution phase 2 trials. So this was over 2,000 men who were treated in the years 2000 to 2012 with a median follow-up of about 7 years. Most of them were low risk, but about a third of them were favorable intermediate, and about an eighth were unfavorable intermediate. Most of them did not receive androgen deprivation therapy. Most of them were treated with the robotic SBRT, that's CyberKnife or similar treatments, but about a third of them were treated using a linear accelerator for the SBRT. And the biochemical recurrences at 7 years are reasonable. They're not great, but remember, these patients for the most part did not have ADT. But the important point was that in these patients who were being followed prospectively, mostly, although one of these was a retrospective trial, but most of these patients were followed prospectively, and the acute grade 3 toxicity was at very low levels, less than 1% for the GU and for GI. The late toxicities were also relatively low, although the GU grade 3 toxicity was 2.4%. So this showed that this treatment can be given. It's a reasonable thing to do. This is not a comparison, obviously, with standard treatment. In other ways of doing this, in Prague at the Czech Proton Center, they treated patients using a similar fashion, 5 fractions with the same dose of 36.25 gray and 5 fractions. And again, their disease-free survivals were similar, and their toxicities were similar to those SBRT series from the US. Now, there have been 2 SBRT randomized trials, which are either completed or nearing completion. There are several others that are underway. The PACE-B was from the UK, Ireland, and Canada. 875 men who did not receive ADT. They were mostly, well, they're about half and half, low risk and favorable intermediate risk. And they were randomized either to 78 gray and 39 fractions. That's actually what was done initially, but then after the CHIP trial was published, about a third of the patients received 62 gray and 20 fractions. And they were randomized against 36.25 gray and 5 fractions. Again, the grade greater than 2, and this is grade 2, whereas the previous study I showed was grade 3. The grade 2 side effects acutely were reasonable, 10 to 12%, and the late, I'm sorry, that was the GI. The acute grade 2 was about the same as well. Those were not statistically significant differences, suggesting that doing the ultra-fractionated regimen gave you the same kind of side effect rates as conventional fractionation. There's another study, PCG-GU002. The PCG is Proton Collaborative Group. We participated in this study, and in fact, we put in the majority of these patients. This was for low-risk patients, and this is a randomization between what was called the standard treatment at that time, which was 79.2 gray and 44 fractions, or 70 gray and 28 fractions, which came along a couple of years after this study started. They were randomly assigned versus 38 gray and 5 fractions. Now, it was a 1-to-2 randomization, so twice as many patients are getting the very short course of treatment. This opened actually at the end of 2010, and we entered quite a few patients in the very first part of this study, in the first 3 or 4 years. However, at that point, we started treating a lot fewer patients with low-risk disease because of active surveillance. And so the numbers of the patients slowed down. And so we actually have had 90+% accrual for the last several years, and it's slowly meeting that accrual, and it likely will close in the next few months. There have been an interim analyses at several points along the way, basically to make sure that there was no significant difference in outcome. The only difference was in the patients who were receiving the SBRT, or the ultrafractionation, at 6 and 12 months. They had a little bit higher urinary bother, both in terms of IPSS and the EPIC scores. But there was no difference in long-term follow-up. There's been no difference in long-term follow-up. The Hypo-RTPC is a Scandinavian study looking at randomization between standard fractionation of 78 gray and 39 fractions versus an ultra hypofractionated regimen of 42.7 gray and 7 fractions. About 1,200 patients were entered. We have a median follow-up, which is now nearly 7 years. There have been no differences in prostate cancer control at 5 and 7 years. I should note, none of these patients received ADT. They were intermediate and some high-risk patients, although most of them were intermediate risk. There have been more acute grade 2 or greater symptoms, GU symptoms, in the ultrafractionated group, 28 versus 23%. Because of the number of patients, this nearly reached statistical significance at 0.057. And there have been more grade 2 or greater urinary symptoms at 1 year follow-up in the ultrafractionation group, 6 versus 2%. That does reach statistical significance. But beyond that, at 2 years and beyond, there's no difference in long-term GI or GU symptoms or quality of life. Just a quick note that Memorial looked back at their patients who had received SBRT, and even the patients who had high symptom scores and IPSS of 15 or greater, they didn't see really high GU toxicity, although you could argue that a grade 3 toxicity of 5.6% is relatively high. But what they noted was, again, most of these happened relatively early and the scores improved over time. So this is a common theme. And you can see these are the different scores looking at different symptoms. Over time, you see that most of these are trending downward. And in the bottom right corner is the overall IPSS score. And you can see that that trends downward over time as well. So it seems that one of the factors when you do the ultrafractionated treatment is they do get more symptoms acutely, but that those seem to calm down over time. Now, in terms of those guidelines that Nasser talked about, there were several that specifically addressed ultra-hypofractionation and basically said that this can be offered to patients with low and intermediate risk disease with prostate sizes less than 100 cubic centimeters. And the quality of evidence on that is only moderate. The quality of evidence for all of these is moderate to low. They also said the same thing about the ultrafractionation that it shouldn't be offered at higher doses unless it's in the setting of a clinical trial or a registry because of the concerns about toxicity. Now, they specifically mentioned the risk of late toxicity. We have not seen that. It's been actually more of the acute toxicity that's been a problem. And the other factor that's seems to be a problem is if you treat these patients in consecutive days, they do have more urinary symptoms. And so if you break this up so that you give it every other day or every third day, then the urinary symptoms seem to be much less. So basically, in summary, there may be more acute side effects, especially the GU side effects, but there does not seem to be a difference in long-term side effects. There are maturing randomized trials. There do not seem to be any difference in the prostate cancer outcomes thus far at 5 to 7 years, similar to the moderate hypofractionation studies that Nasser presented. And we need a lot more data on the high-risk patients. It has been used in some high-risk patients, but primarily this has been used for patients with lower intermediate risk patients. So with that, we'll stop for now and move into some questions. I guess I would throw the first question to Dr. Califano and ask what do you think the issues are? Issues or problems with offering hypofractionation most small prostate cancer?
I'm sorry, Bill, we couldn't hear you.
So what are the issues or problems with offering hypofractionation to most or all prostate cancer patients? What do you see as the obstacle?
Yeah, thank you, Bill. And I think can you hear me?
Yes.
Okay, thank you. Thank you, Bill, Nasser, Radil, Steve, and those were excellent presentations. And, I think it's great that our discipline has got all of these options to offer to our patients. And Bill, as you mentioned, this is not anything new. When I first started training in radiation oncology, we used the Manchester technique where we gave 5,016 fractions. So the prostate cancer treatments were done in 3 weeks. And now, 25 years later, we go from 8 weeks back to 5 weeks. So the question really is, what is different about this hypofractionation regimen? Certainly the plan that we do for one treatment is the same that we do for 5 treatments, is the same that we do for 25 sessions. So the technique is not an issue at all. I think we are all capable of doing it. If the dose per day is significant, then I think we all should do it. But unfortunately, as you all rightly pointed out, the only trial that aimed at superiority was the Alan Pollack trial of hypofractionation, which did not bear out. So I think we can say they are equivalent. And so if the hypofractionation is equivalent, then the question becomes, if cost is the issue, certainly cost is a valid concern, then I would argue that you can do brachytherapy in 1 day. And even if you combine external beam and brachytherapy, it will be done in 4 or 5 weeks. So, so I think the issue really becomes, if it is cost, which is a value, which is valid, I think certainly this can be offered to patients with intermediate risk. My biggest concern, and having a urology audience is always helpful, because they always think from the perspective from diagnosis. So you can imagine, for all the urologists on the call, the one thing we don't do is we have not used hormones in most of these trials. We've not treated the lymph nodes in any of these trials. So in patients who are at a higher risk for lymph node involvement, especially as you go from low intermediate to higher, unfavorable intermediate to high risk, they're getting 0 dose to the nodes. And all of us who have been doing this for a decade or more know that the major pattern of failure, the local recurrence comes 5 to 10 years and the nodal recurrence comes soon. And my concern has to do with the omission of nodal treatments in the higher and unfavorable risk groups. And as you pointed out, there is a slightly higher rates of toxicity, especially GU. So in patients, I know some of you mentioned 100 cc's, but most of the trials that accrue these patients use a cutoff of 60 cc's and an IPSS score of 15 or below. So I think we should stick to the volume considerations and the IPSS scores that have been used. And the last point I would make is we all know the problems associated with biochemical relapse using the Phoenix definition. When we started doing brachytherapy 20 years ago, one of the gold standards was biopsy at 2 years. And as you may know, there is a trial conducted out of Memorial that looked at doses from 32 to 40 gray. They added 30 patients each. And the 2-year biopsy positive rates for these patients in the dose ranges we are talking about were about 15 to 18%. One can argue with how accurate positive biopsy ratings are. And the authors conclude that the dosing needs to be looked into. And for those of you who've had discussions with me about the optimal dosing, I think the Memorial group would agree that we probably need to go higher. The Dallas group thinks they went at 10 gray times 5, and they had some problems. For all other malignancies, when we want to ablate tumors with curative intent, we go to 1,000 times 5. So I just have a little concern that our doses may not be high enough to cause a durable 10 plus years control. And whereas with external beam and brachytherapy, you have excellent ablative potential, treating the nodes, treating the prostate to the highest dose. And so I think, to be fair, there is a significant body of evidence that shows that this is safe, effective, and should be adopted with the caveats that I mentioned, meaning that they should not be considered in patients who have had TERP, high IPSS scores. They should not be considered in inflammatory bowel disease and larger prostate glands, and also with intermediate and higher risk, mainly because we don't treat the lymph nodes. Thank you.
Thanks, John. Maha, you had a question?
Yes. Maha, do you have a question as well?
Yeah, I do actually. So thank you for the presentation. I have a couple of issues. I sit on the other side of the aisle and I end up seeing all those patients who end up failing. And clearly the percentage may not be high, but there is that failure rate in people who are intermediate risk who just got prostate only radiation. And so I am concerned about the whole issue of balancing, obviously, risk and benefit. And to me, the biggest risk is disease-related risk. So I was curious about the trials that were mentioned in one of the presentations regarding non-inferiority design. And clearly, the devil is in the details in terms of what counts as non-inferiority. Can you make a comment as to what was considered non-inferior? What was the power for it?
Yeah, it's a tough one. If you go on and come right back, I'll look it up for you.
Yeah, no rush. I mean, you can answer me later. The reason I say that, to me, having designed myself non-inferiority trials, as I say, the devil is in the detail. If you say a 20% difference will be considered non-inferior, then that could be a big chunk. Whereas if you say we're going to look for a difference of 2% only, well, you're going to need like 10,000 patient trial, which makes it very difficult to do. So I do think there's some subtleties, and I know that the panel from ASCO, AUA, and Astro had endorsed it, but it seems to me like some issues need to be revisited.
Yeah, I'm looking it up right now. I'll get right back to you.
Yeah, Maha, I think I share your concerns. And I think one of the main sticking points, and as I'm sure the urologists in the group know, that the percentage of overstaging with, after surgery, right? You can quote numbers of 20 to 40% overgrading, overstaging, especially with the vesicles and lymph nodes. I think that is the main problem when we apply these techniques that limit the volumes being treated, is that we may fail beyond the periphery. And I can assure you that the margins we use for higher and higher doses of radiation are smaller and smaller. And now we're using MR-based technologies, and our margins are almost 0 to 3 millimeters. So I mean, certainly this is very, very doable. But I think when we see our patients, I think it's good to have a healthy mix of skepticism. Just for the patient's sake, I don't mean to critique this at all. I think we're headed in the right direction.
Agreed.
So, Maha, in answer to your question, the way that the CHIP trial was designed, that's the largest of the three that included all 3 risk classifications and has updated with a 9.2 median follow-up. That was designed to a non-inferiority margin of 5% with 80% power.
Okay, so that's pretty tight.
Yeah, and that had over 3,000 patients enrolled in that study.
Yeah.
Was that the 5% difference? Was that in survival in biochemical disease control, or was that toxicity?
So the biochemical. This is the CHIP trial's primary outcome was biochemical failure.
Okay.
And was that at a specified timeline or any time of failure?
Another good question.
You know what I'm saying? Like, is it at 5 years? Is it at 2 years?
It's 5 years. 5 years.
5 years. Okay, which is fair. I think that's a pretty reasonable design.
I know Ted has a question as well.
I do. So just to follow up to one of John's points, which is for our group at Northwestern Medicine, if the patients are offered, a conventional or just hypofrac or ultra hypofrac, which patients are also, or how are you thinking about lymph node coverage? I know that, as John alluded to, many of the trials did not include that. Is that something that you guys do in practice, in real practice? And if so, what are your criteria, or how do you think about that?
Yeah, so Ted, I think that's an excellent question. And I think that gets to the heart of the indications for these treatments. As you know, we are now basically limited to intermediate risk and high risk. We've as Bill mentioned, we don't treat the low risk. So we have certain formulae that we use, the Roche formula, 2/3, PSA plus Gleason score minus 7 × 10, which is a very conservative estimate of lymph node risk. Then we have the Canadian group after radical prostatectomy and lymph node sampling, where they've included that there's a nomogram for percentage biopsies that are positive. And I think a lot of that is included in the unfavorable intermediate risk categorization right now. And on top of it, you now add 3T MRI, and some of the trials that are currently looking at these hypofractionated regimens indicate that the 3T MR should not show any evidence of disease that goes to T3, or that the 3T MR should not show evidence of T3 disease. So, so if you use the Roche formula, the percentage of positive biopsies more than 50%, and of course, clinical stage, we catch them early for the most part, So, and if you use a 3T MR, I think all of these 4 criteria is what I use to determine lymph node risk. And if there is any suspicion, we treat the lymph nodes.
Yeah,
I guess the question was, thanks, John, for the other folks on the call. When you're considering for somebody who, so is there a difference in your determination of lymph node field or not if they have conventional fractionation or one of these alternate regimens? Is it that you decide about lymph nodes independent of approach to managing the prostate? I guess that's my question.
Okay, so this is Bill. I'll jump in.
Bill or Nasser or somebody.
Yeah, if we have a patient that we think needs to have treatment of the lymph nodes, typically we will not do the ultrafractionation, but we will do moderate hypofractionation. The decision between the conventional fractionation and the moderate hypofractionation is based on other factors. If you have a patient that has big median lobe with an IPSS score of 25, despite what the AUA ASTRO-ASCO guidelines say, we're much more likely to do conventional fractionation on that. But for most of the other patients, we would do moderate hypofractionation considering. As John said, we use one of the formulas. Typically, we use the MSK nomograms, and any patient who has a certain risk of lymph node involvement, we will typically treat the nodes unless there's some kind of confusion. My cutoff is typically 10 to 15%. So patients over 15%, I would treat. The ones 10 to 15%, I would consider based on other factors.
Yeah, and Otto Akhtar here, I think this is where the use of advanced technology could come in with techniques like simultaneous integrated boost. It doesn't have to be a binary thing where it's only conventional fractionation or hypofractionation. As I think Nasser is showing here, we're able to combine both whereby we're treating the nodes with conventional fractionation in some of these higher risk patients, but in the area of the prostate where we have the data to safely do so, we're treating with moderate hypofractionation, so we can combine approaches.
Thank you. Yeah, I think there'll be a whole new era of management of lymph nodes when PET-based tracers are more widespread in use. So that'll be a whole other Wild West show, I bet, as well.
We're still waiting on the data from RTOG 0924, which is the largest prostate cancer trial ever run by the RTOG. I think this is the largest prostate cancer NCCN trial ever run, which will address that question. There's been some preliminary data. There was a trial that resulted in ESTRO this past year, which showed improvement in all outcomes with the addition of a lymph node field to anyone who had high-risk prostate cancer. My own practice is I treat everyone with high-risk prostate cancer and or if they have a high risk of lymph node involvement.
Yeah, Sean, I'm with you. I end up treating the nodes more often than not, especially for high risk, risk over 15%. And in these, generally for these trials that I went over, like the CHIP trial excluded patients if there was any risk greater than 30%. So you could not be on the trial if your risk of nodal involvement was over 30%. And thanks for we talked about how all the trials excluded nodal involvement. I think it was the Fox case study. I think they did include nodes with hypofractionation, but just the technique, and I'll touch on this now. I think you can treat the lymph nodes, and you can do so safely, and it ends up being the same as you would do with standard fractionation. Instead of boosting in two separate treatment plans, you can get it done in one. Now, of course, the trials that we talked about did not do it that way. But if you, as the clinician, feel that the nodes are at a higher risk, then I don't see, we've certainly been doing it for a while, and I think we do. The patients do well.
So it's getting a little bit late past, and I think that's just a testament to how good Dr. Hartzell's, Akhtar's, Mihalek's, and Mohammed's presentations were, and the great discussion by Dr. Kalpurikal, Sean, and the rest of our team. Just remember, we're a CME course now, so there'll be a survey being sent out to you. Please give your feedback so we can keep getting CME credit for this time. The talks, again, were wonderful, and unfortunately, I'm leaving the conference more confused about what the right thing to do is and when than not. But fortunately, I'm not a radiation oncologist, so I'll leave it up to the group here. If there's any final thoughts, otherwise we're 10 minutes over, so we can.
The only thought I would leave I think everybody with is I think if we treat patients definitively, especially the younger patients, I think we should wait for the best, longest data, because if we are erring on the side of a lower dose, and if that is for patients in their 70s, I think that is one thing because it may not matter. But for our younger patients, I think we should be cautious with these modalities because they do not have a backup treatment option for the most part. And I think that's where these problems come in. Thank you.
Thanks, everybody.
That's why I wanted to have the vote before and after.
That's it. We can send out, Mary Kate, if you don't mind, in addition to the survey, send a quick email question saying how many of you would do moderate hypofrac and how many would do intense ultra hypofrac for an intermediate for an intermediate risk prostate cancer patient with an IPSS of 8 or low IPSS. And we will see if we can get some data for Dr. Hartzell.
Thank you.
Thank you. Thank you, guys. Great talks. Thank you.
Thanks all. Have a good
Thanks
night.
for having us.